Welcome, everyone. We are pleased and proud to bring to you the launch of the Disaster Response Collaborative, which is focused on children's hospitals. Next slide, please. The Pediatric Pandemic Network is supported in part by the Health Resources and Services Administration of the U.S. Department of Health and Human Services as part of several cooperative agreements. The content presented here is that of the authors and does not necessarily represent the official views of nor an endorsement by HRSA, HHS, or the U.S. government. For more information, visit hrsa.gov. Next slide, please. So you're welcome to test the chat box. You may only be able to chat with the presenters, but you certainly can talk to us in the Q&A box. We do want you to put your questions and any comments into the Q&A box as you come up with them, and we will either answer them throughout the presentation or at the end during the Q&A session. Yes, the slides will be shared with you after the session. The webinar is being recorded, and both of these items will be posted online and emailed out to you. Next slide, please. I'd like to turn it over to Kevin McCulley, who's the head of our Pediatric Pandemic Network.
Great. Hopefully, Laura, you can hear me okay?
I can. Thank you.
Great. Thanks. And apologies if you guys hear a dog in the background. 11, 12 o'clock is always the mail. What a great opportunity that we have to take the work and the foundations that have been set by the Disaster Networking Collaborative as we start to roll in to the Disaster Response Collaborative, really to dig deeper into some specific topic areas, really beginning to think about how to operationalize the preparedness work that many of us do every day and translate it into a ready-to-respond system that can actually have tangible benefits when these bad things happen, whether they're local to your facility, regional, statewide, or national events. As I thought back about the call to action and about how it's noted in here that the time is now, you know, it used to be that we did preparedness planning for some event that has yet to occur in the future. And then with COVID, we understand there was certainly more work to be done to be ready when these events take place. But actually, as I was looking back from the start of the Pediatric Pandemic Network to today, our healthcare systems, and in particular our children's hospitals, have been involved in some sort of a response, basically since the Omicron surge of COVID, whether it's triple-demic, mental health boarding crisis, fires, a hurricane in California of all places, and a variety of other human-caused and natural disasters. So for me, that rings very true that we're not necessarily preparing for something in the future. The time truly is now. And before I turn the conversation to our other guests, I just wanted to give a quick story that really reinforced the criticality of connectedness in this work and scalability. Next slide. So as we think about the PPN and its 10 hubs, I realize this is an incredibly busy slide, but what I want you to take away from this is each of the partners brought something to the PPN during our original application and continue to lead a variety of efforts within the network. However, although we're founded on a network of 10 hub sites, there are many other partners that have joined us along the way. That includes our pediatric disaster centers of excellence in the west to the south and in the Great Lakes region. Our national organizations, Children's Hospital Association, AAP, PCARN, and many others, and critically, a number of other institutions that have joined us to bring their expertise to bear as we move forward with the PPN. Whether it's Dell with the work with EIIC, quality improvement and readiness work, much of which has led to the development of the DNC and the DRC, or whether it's our partners at Nationwide Children's leading a lot of our research and innovation work. The call to action for you is that participation in a QI collaborative is entirely voluntary, but it doesn't have to be the end of the connection with the PPN. So if you are interested in looking at, and you can go to the next slide, if you're interested in looking at opportunities to get involved in one part or another of the network, thinking about our work on readiness, resiliency, response, and research, I absolutely encourage you to reach out to us. And if you'd like to get involved in one of the domains or participate in some other way, we would love to have you. So back to my story. We got the call. Passenger on the Diamond Princess, early 2020. Thinking about connectedness and scalability. Next slide, please. Couple of questions I'll present to you. Is your infectious disease leadership at your institution aware of ID response plans? Are they leading it? Are they ready to come up with a number of state leaders and say, yes, we are going to take a patient from the Diamond Princess? Next slide. Have you worked out with your EMS partners and your public health response partners special pathogens transport plans that could be activated in 6, 12, 18 hours in anticipation of receiving a patient with an unknown respiratory pathogen? Next slide. Are you coordinated around this issue of not just receiving, but actually the logistics related to transport of these individuals? Is that special pathogens plan in place in a way that it could be activated at a moment's notice? Next slide. Sure, many of us have worked in special pathogens in the development of biocontainment and other in-hospital and out-of-hospital partnerships. But the question is it ready to be activated, or have we lost that window from Ebola to Zika to coronavirus to now? Continuing vigilance to me is absolutely critically important. And as it turns out on the next slide, all the guy wanted was some Cheesecake Factory. And we absolutely used a huge amount of resources just for that one individual because we were ready for action. Next slide. Coordination with jurisdictional emergency management is absolutely essential to successful participation in disaster responses. And as I looked back, next slide, please, over COVID, when we had our early COVID organization chart, and this was for state of Utah, even from the smallest piece of the org chart, there were numerous numerous elements of coordination going on with our healthcare system partners that has to be built in to response plans. whether it's recommendations to medical direction, coordination in the policy group, or coordination around logistics, the provision of healthcare, or epidemiology. However, as we think about these as maybe one-off events, we also have to think about scalability of this system, because it wasn't soon after we got the call for one patient, we got the next call. Next slide, please. We now have inbound 37 patients from the Grand Princess. What are we going to do with them? Next slide. Thinking about the scalability of a system to go from 1 to 37 in about a week. Next slide. Lets you understand how important not just preparedness, but readiness to respond becomes. And this is the arrival of the Utah 37 from the Grand Princess into our state in the early stages of COVID. Next slide. And then finally, as you think about a system scalability, or you think about expanding incidents, have you all considered all of the areas in which healthcare partners are deeply involved with a jurisdictional emergency management system? And can you actually make it work at the time that it's needed? Next slide, please. I'm going to go ahead and pass the time over to Joelle Simpson, one of our co-PIs of the Pediatric Pandemic Network, to start to get you into today's content. I thank you very much for your attendance, your time, and very much look forward to walking this path with you all. Joelle?
Thank you, Kevin. I'm excited to you got us all energized about the need for us to be here. And I want to give a little bit of a backdrop about the Pediatric Pandemic Network. Some of you that are joining us were part of us for the Disaster Networking Collaborative, but some of you may be new to this call and not have gotten some of the backdrop of what the PPN has been all about. I think to speak to what Kevin mentioned is that we have more so than ever, especially through the pandemic, appreciated the magnification of our strengths in coming together around children and the issue of children and being ready for children in disasters, no matter what our discipline, whether we be like me, a pediatric emergency medicine physician, our nurses, our emergency managers, our public health workers. We've realized the importance of sharing resources, exchanging ideas, realizing the gaps that we have in our own entities so that we can learn from others to close those gaps and have a situation where anywhere that a child shows up in our system, we have plans, we have equipment, we have staffing and skills that are ready to care for them in an emergency and in a disaster. So the Pediatric Pandemic Network, certainly with an infrastructure of 10 children's hospitals, but as Kevin showed, a partnership with many other hospitals, children's hospitals, pediatric departments, community hospitals, public health agencies, and large networks such as the Pediatric Disaster Centers of Excellence. We're coming together on the heels of the Disaster Networking Collaborative, where we learned so much about relationship building, talking to our C-suite executives, and understanding the infrastructure needed, and now ready to take on response. How do we truly show up for when an event occurs? What have we learned from events that have occurred in the past? Where's the gap there? And how do we fill in for each other in partnership with our colleagues across the emergency management space, not just for kids, but communities, the adult systems, et cetera, in order to be better ready for children. So sitting as a co-principal investigator of the PPN and also being a lead principal investigator here in Washington, D.C., I love this picture here that shows sort of my roots in emergency management, which was when I was leading a pediatric medical reserve corps and working in the communities to respond to a lot of the mass gathering events that occur in D.C. And response can occur in all levels, as you all know. It can be something to the scale of a global pandemic. It can also be something to the scale of a mass casualty, and many other events, and sometimes to events where we are continuously trained and reinforce the skill sets that are needed in order to respond to our threats. Next slide. So the why, hopefully that's already sort of somewhat been answered, but we really have to, and we'll explain a little bit more through this talk and the other speakers, the importance of prioritizing children in planning and being able to sit at those tables, whether it be in a regional coalition or in institutions, to address the needs and the issues of children. We want to get us all motivated here. We want to talk about some of the big issues at hand, such as the financing of these efforts. What are the metrics that are needed to say that we are actually successful? We are collaborating through the Disaster Response Collaborative and using the leverage that we've already been gaining, the momentum gained, not just from the Disaster Networking Collaborative, but also the infrastructure being built by the PPN and the Pediatric Disaster Centers of Excellence. This is grounded in science, in quality improvement science. I myself am not a quality improvement scientist, but I've certainly gained and learned a lot from the participants of these collaboratives to better understand how to speak the language to stakeholders that invest in response and in the efforts of emergency management. That's sort of the perfect segue to our next speaker, Kate Remick, who is a quality improvement expert. And she will talk to you a little bit about where we came from the Disaster Networking Collaborative and where we're headed with the meats and bones of the Disaster Response Collaborative. Kate?
Thank you so much, Joelle, and welcome everyone. It's really nice to see so many people on this call. I'm based out of Dell Medical School at the University of Texas in Austin, where I serve as co-lead for the quality improvement work within the Pediatric Pandemic Network, and it's really great to have all of you here. So if you could go to the next slide, please. So I just wanted to start with a little bit of background, and I know that Kevin did a really lovely job of framing this in the context of specific events, and these pictures that are shown on the screen here certainly depict a number of events over the years, from, of course, the towers to Hurricane Katrina and Tornado Alley and the Boston Marathon, and of course there have been many more recent events. But what should really draw your attention is that when we look at the current state of readiness to care for children among all hospitals in the country, fewer than 50% report that they include pediatric-specific needs within their disaster plans. And there are ongoing deficiencies in our day-to-day ability to manage even the most critical single child. And that is only exacerbated during the setting of any kind of disaster or pandemic event, as we've witnessed over the last 5+ years. Unfortunately, many disaster plans, even at the state and regional levels, do not include pediatric-specific considerations. And this is why there's led to the need to develop pediatric annexes and really begin looking at how are we managing children in the state of disasters, because they are disproportionately affected due to their physiology, communication skills, reliance on adults, and the like. And what we found in many of these situations as we begin to explore regional disaster plans is that oftentimes general hospitals rely on children's hospitals as their sole solution to handling the influx of pediatric patients. And this is really why it's critical for children's hospitals and children's hospital leaders to be thinking about pediatric disaster preparedness and how we can build out our own disaster response capabilities, but then in turn strengthen our regional disaster response capabilities. Next slide, please. If you look at the approximately 200 children's hospitals that exist in the United States, we know that the great majority have neonatal and pediatric intensive care units and services and pediatric wards and newborn nurseries, which is why so many general hospitals often turn to us for support during surge events. If you look at the 5,000+ hospitals overall, you'll see that many of them lack pediatric wards and pediatric intensive care units and neonatology services or newborn nurseries. And it's for this reason that we really need to think about how are children's hospitals working collaboratively to be able to meet the needs of our country? Because certainly the 200 children's hospitals alone cannot meet the need of every single pediatric patient with an emergency in a given time period. There has been the development of a national checklist to help guide hospitals in meeting the pediatric disaster needs for their communities. And this is described in the checklist of essential pediatric domains and considerations. It's located on the Emergency Medical Services for Children Innovation and Improvement Center website, which is really a sister network to the Pediatric Pandemic Network. And this checklist outlines 11 domains of focus for every hospital to ensure the integration of pediatric needs into their overarching disaster plans. And this really becomes the foundation for much of the work that we are embarking on within the Pediatric Pandemic Network, but even more specifically within the Disaster Response Collaborative. Next slide, please. This provides a high-level overview of the trajectory for the Pediatric Pandemic Network over its first several years of existence. We started in late 2021 as 10 children's hospitals that were federally funded to really begin thinking about how do we develop a more coordinated national response of children's hospitals when the next disaster, pandemic, or surge event hits. And really beginning to bring together the nation's experts in creating and centralizing pediatric disaster resources that could be used to help educate and help serve as tools during specific disaster events. But we also realized that 10 children's hospitals cannot do this alone. And there is an enormous need to begin to build a national network of children's hospitals so that we can begin to respond in a more coordinated way and support each other, starting with initial relationship building and understanding of our own current states of pediatric disaster preparedness, and then really beginning to build up our capabilities in terms of disaster response. We started with a disaster networking collaborative last year, and we're so excited to have approximately 100 children's hospitals that signed up to participate with us. And in this particular quality improvement collaborative, we are really trying to strengthen the pediatric disaster leadership roles within children's hospitals, bring awareness to hospital leadership about the importance of pediatric disaster response, the role of children's hospitals, and really to establish a stronger foundation of disaster leadership within these children's hospitals. Our next collaborative that we're about to embark on is called the Disaster Response Collaborative, as Joelle mentioned. And this is really with the intent of, now that we've identified and strengthened our leadership and the commitment of children's hospital administrators to disaster work, how do we begin to improve our disaster response capabilities, build those networks, and really learn from each other about how we can do better? And our ultimate vision truly is to create a greater national network of shared learning between children's hospitals, where we can have ongoing collaboration and coordination in response to large-scale events, and eventually to become really the collective voice for pediatric disaster preparedness and response in this country. Next slide, please. Our emergency care systems are very complex, and disaster science is indeed quite young in terms of the provision of evidence-based guidelines and practice recommendations. But the reason that we really lean on quality improvement collaboratives is, albeit disaster science is young, there is a real need to immediately begin to adopt evidence-based practices. We know that if we have manuscripts published relative to best practices and clinical guidelines, that on average it takes about 15 to 20 years for that to be adopted into clinical practice. And instead, we use quality improvement methodology as a more effective tool in rapid transformation of our healthcare system. And typically, when we use quality improvement methodology, it involves active learning, shared learning, and it leads to usually a 3 to 5 year period for adoption rather than that 15 to 20 year period. And our goals are really to drive research into practice and use data to really measure the impact of our work. Next slide, please. As we've mentioned, we really rely on quality improvement collaboratives because they offer a shared learning network where we can drive that research into practice, but also begin to generate new knowledge through diverse institutions, learning from specific methods of adoption and the specific barriers and enablers to being most effective. And we do this through the use of data analytics to measure our impact. All quality improvement collaboratives are based on these key pillars that are outlined here. So we use evidence-informed content. We use quality improvement methodology. We have centralized project management support to help guide teams. We have IT infrastructure to help facilitate ease of participation, as well as data management that then allows us to really look at measurable impact of our work in order to eventually generate new knowledge in the form of research. Next slide, please. So the two collaboratives that we've really outlined in the Pediatric Pandemic Network, first were this disaster networking collaborative to really build out the foundational elements within children's hospitals, strengthen the local disaster leadership, and begin to develop regional partnerships. Within this disaster response collaborative, we're really trying to move towards a more robust national response network of children's hospitals, where we can really dive into what are our pediatric disaster capabilities, knowing that children's hospitals really serve as the key pillar or the gold standard for pediatric disaster response, help to establish some baseline standards for what that looks like, and really begin to strengthen and build our network of children's hospitals. Dr. Sarita Chung will be speaking about the specific areas that we'll be focusing on within the Disaster Response Collaborative. You'll see those highlighted, very small font on your screen, but they, as I mentioned previously, they build on the foundation, which is this disaster checklist that outlines 11 domains of focus. So with that, I'm going to turn it over to Dr. Jonathan Eisenberg, who's going to speak a little bit about some lessons learned from the Disaster Networking Collaborative and beyond.
Thanks, Kate. We can go to the next slide. I'm a pediatric emergency medicine doctor at Dell Children's, and I work with Kate, and we also do the QI PPN service corps together, along with some of the other folks on this call. So I wanted to just kind of touch on some of the things that we've learned from the DNC, and then talk about how the DNC is going to sort of overlap with the DRC, moving into its own kind of unique collaborative, and then some of the future items that you may just want to keep in mind when forming your team for the DRC. So this is just a brief graph, pie chart, kind of looking at both the type of children's hospitals that were participating in the DNC, as well as the team member roles. And I think just a big takeaway from this is it's just great to see the diversity of the team member roles, in that it's not just the nurse manager or not just the physician, but also we have a huge other category. And I don't know who those others are, but it's not just the disaster medical director from the hospital, it's all the other team members. And I think that only helps us strengthen and broaden our approach to both disaster medicine as a science and your particular response as a hospital system. I can tell you we do some small group chats within our DNC lectures and webinars, and it's been great, the exchange of ideas that we've had from all the different sectors that are involved with the DNC, and I think that'll only continue as we move forward with the DRC. All right, we can move to our next slide. Great. And this is just a mid-collaborative environmental scan that we did for the DNC. This was about 1/3 of the participants of the DNC. And I think just some takeaways from this, some really great high numbers looking at EM landscape management and people who took some improvement steps in the roles and responsibilities category, but definitely still some areas that need improvement, specifically the C-suite commitment and support, and some of that roles and responsibilities to where there was no action taken but you don't feel that you're fully informed or a fully formed team yet. So, the DNC's job was to really hit these 3 categories and make sure that we have a good background as we're launching into the next collaborative. So I think trying in these next few months, if you haven't already, to just sit down and speak with somebody in your C-suite. There are some handouts on the DNC website that are very useful for both conversation and also ensuring that the roles and responsibilities are outlined, and make an effort in the next couple weeks to engage in your EM landscape if you haven't already. It'll only help for the next iteration. All right, we can move to the next slide. So some things that we took away from the DNC is a robust team. So really engaging everybody in the hospital. It's not just the emergency manager or the emergency department that's taking on a disaster. We need to have infectious disease involved. We need to have the hospitalist, the NICU, nurse management, security, engineering. So when you're forming these teams, really try as best you can to reach out to the people that you may not feel like have a seat at the table all the time. We really learned how important C-suite commitment and support is. It's critical for our preparedness. Not that they're going to be boots on the ground, but they are very important as a voice for us in hospital leadership to ensure that we have the protected time and financial support to ensure that our role can continue. As well, these collaboratives are not easy, both from the planning side and from the action side. So it's great and super important to have this collaborative to help guide teams and provide the resources that you need. It also serves as a bit of a motivating tool if you know that you have something to kind of answer to. So joining is both great for your particular hospital. It's great for the robustness of the DRC, and we have to kind of practice what we're studying. So next slide. So what are some of the goals for the DRC? Initially, and I kind of think of this as DNC, the overlap of the two, and then the DRC. So first, the early overlap is we're really trying to nail down the pediatric disaster response capabilities of a children's hospital. And then number 2, we're assessing the current state of the disaster response from the participating hospitals. And so far, we've had some environmental scans showing us that there are certainly some gaps and some areas that need improvement. And with the DRC, we're going to have an even more robust evaluative measures to really hone in on what we can do to better ourselves. If we're more at a foundational level, how can we get to that advanced level? If we're at an advanced level, how can we be a leader? 3, establishing a sustainable network of children's hospital leaders actively participating in disaster planning and response. Dr. Remick was mentioning that in her talk about the need to really create this robust response and planning forum, and 4 is creating that forum to drive a coordinated response for all the children's hospitals when there is a national disaster or surge event. And then 5 is really where the DRC is going to make itself a little bit more unique, and is that we're supporting teams to drive evidence-based or consensus-driven regional pediatric disaster planning and response. So I'm going to get into that. We can go to the next slide. So phase 1 is really looking in depth into our focus areas, and Dr. Chung will speak to those in just a moment. But our goal is to use tabletop exercises and different types of drills to monitor and then demonstrate improvements in response through QI methodology. And then teams are going to be selecting a specific area that they want to improve on. And that can be 1 or 2 areas, depending on the size of your team and how you feel you are prepared. The initial DRC is going to start in August 2024, and it's going to move all the way through June 2026. And we create that longer timeline so that you have time to meet, the focus area groups can meet, you can facilitate pediatric disaster response improvements, and you have the time needed to test out those improvements with exercises and drills. The goal for participating sites would be to set the structure, which was a little bit on the DNC side, and then the process, which is going to be more the DRC. And and then work on implementation of that protocol or process for the drills and exercises. And then ideally in the phase 2 portion, really expanding that into a regional drill. And we can go to the next slide. For those who are a little bit more of a visual learner, the timeline, August is when we're going to have our initial overviews, and then we're going to have some overviews of the specific categories from the domain checklist: evacuation, surge capacity, reunification, and triage, infection control, and decontamination. We're going to talk with our drills and exercises folks, and then we're going to have some focus area sessions, bring it back to the large group, focus area sessions, large group, and go on like that, with areas in between where you're working with your individual teams. So I know that we had this discussion, what seems like a long time ago, but it was just a few months ago, as to how to build your team for the DNC. And it's really similar to the approach for the DRC. It should be multidisciplinary. Like I said, it'd be great if we could have emergency management, emergency physicians, NICU, hospitalists, ID, critical care. I don't think nephrology is going to be super interested, but if you want to get them involved, you need emergency dialysis. But everyone should be offered a seat at the table. The more robust the table is, the better your team will be. And then leveraging those strengths of each members. Everyone brings something different to the table. We can go to the next slide. So we found that some barriers of successful teams were people just want to change positions or opt out. And that's fine. The reason that we suggest that you have 4 to 5 member teams is because there is going to be some attrition. There's going to be someone who's going to drop out. But things that we found that have been successful is staying focused on what the team has decided as sort of a goal. And we always suggest starting with a SMART aim, and then having, if not weekly, try at least monthly communication. I know it's hard to get bombarded with emails, but within your own team, just ensure that you're keeping yourselves accountable and keeping yourselves on task. We can go to the next slide. So not to dwell too much into this, but this is not easy. It takes a lot of effort. The reason that we're championing the DRC is to create this network, engage, enhance our skills, and you will have access to the experts and resources, both from a QI perspective and the disaster medicine perspective, that you need to improve performance, measure your improvements, and then innovate and address those risk and liability reduction measures. Like I said, we really want to form a robust team, make sure that there's people from all different areas of the hospital engaging with the C-suite to ensure that they know what you're doing, because that will only help you in moving forward. And then we'll kind of get into the timeline a little bit, but in early 2025, really trying to figure out which area you want to focus on, and then identifying and testing improvements with the tabletops and larger drills, and then eventually becoming a champion for your local area to then broaden it to the whole EM landscape of your region. We can go to the next slide, where Dr. Chung is going to speak about those specific areas. Thanks so much.
Hi, everybody. Thank you so much for joining. My goal today is really just to talk about the 4 specific areas of the focus groups. I was told to put in a fun slide. So this is a slide of when I deployed to Haiti after the Haiti earthquake, and I was being taught by this gentleman on the left, a neurosurgeon, how to do a ventriculostomy on a patient. So that was a very, it was a new skill for me. And I don't think I'll ever do it again, but now I know how to do it. Next slide. So really, and thinking about the focus areas, and first of all, I want to say that this is a lot of information at you, and definitely the DRC is meant to hold your hand throughout the process. It's really to really think about a stepwise approach to how we in children's hospitals can have better planning, better plans, and really be able to respond. And so for the 4 areas for this DRC that were chosen were evacuation, family reunification, surge capacity, and triage decontamination. Next slide. And so these correspond, as we said before, to the EIC disaster checklist domains 3 through 6. Next slide. For the focus area and evacuation is really, and all of these are going to be staff, stuff, space, and structure or plan. And so really thinking about what metrics you are going to have for evacuation, what supplies you need, and then how can we drill and exercise this? And then what are the transport services needed? I think we can all agree that for a pediatric hospital to evacuate, it's going to be all hands on deck and really a regional approach. So really thinking about the tools and the plans that are needed for evacuation, first within your hospital, but second, then outside of your hospital. Next slide. Family reunification, for those of you who don't know me, this is my first love, but thinking about really tracking a reunification, family reunification planning, what spaces are you going to need to use, what staff you're going to need to have, and really this is a multidisciplinary approach within the hospital, as you'll need to think about social work, child life, chaplain services, security, among the many other major partners. Next slide. And thinking about QI, actually, Children's Hospital St. Louis really took the QI approach, and this is their fishbone to thinking about what they need for people, space, process, and equipment, and really just drilling down deeply to say what are the things that we need in family reunification. And so similarly with this collaborative, we would also work with you to think about in your hospital, who are the players, what are the things you need, where do you need to go, and to really make a robust family reunification plan. Next slide. The next focus area is pediatric surge, and really we've all experienced the long infectious surge or even the triple-demic, but this is really also thinking about the no notice event. Are there ways, best practices that you augment your capabilities in the ED, surge, ICU? How do you care for patients that may not be able to be transferred up? What are the surge capabilities within your hospital, but also within your region, alternate spaces that can be used, equipment and supplies, and also once again thinking about staffing. Staffing is probably one of your most important things in all these areas, but also thinking about how do we surge up for a pediatric surge. Next slide. This is just an example of what we did in Massachusetts and thinking about what are our capabilities. This is an example of what we have in Massachusetts during normal hours and thinking about different types of respiratory support and then dialysis. And then, then later on thinking about how can we augment that in a disaster. Next slide. And so the last focus area is also triage, infection control, and decontamination. So really thinking about what are your protocols for that patient who has a very infectious etiology, such as Ebola. How do you isolate? What are your family protocols, family presence? What is the PPE like? And how do we train our staff to really be cognizant of those high risk but low frequency events? And then thinking about hazmat, your decontamination, how do you perform decontamination with kids? Are you worried about hypothermia or the pressure of the water? How do we make sure that they're safe? How do we not scare them while we wear these PPE outfits? And so really thinking about all those considerations. How do we not drop a baby? Things like that. Next slide. So those were the 4 areas, kind of in a nutshell, focus areas that we will have with the DRC. And now I'm going to turn it over to my esteemed colleague, and he's very amazing, Dr. Brent Kasny, to close us out.
Thanks, Sarita. And kind of in the vein of Sarita's picture, this is a picture of me next to a pickup truck during Hurricane Katrina, assisting with evacuation of patients from Charity Hospital. My back is turned. That's me with my hand on my hip, with very dark brown hair as opposed to my hair color now. So next slide, please. So what do we really hope to accomplish through this? And I think the simplest thing is just having a team that's going to champion the efforts of pushing the needle to improve your hospital's degree of preparedness and ability to respond for minimum one of these 4 focus areas that Sarita just outlined. And so we need folks to champion these efforts at their hospitals. And ideally, this is not just an individual, but a team of individuals, because we know that this work is a tremendous amount of work and requires an entire team approach. Next slide. So why should you join the DRC? I think there's a number of reasons, but we've kind of put together this top 10 reasons slide, and I just want to go through them very quickly. But really, I think one of the things that we've seen through the Disaster Networking Collaborative that we hope to continue is just the ability for the DRC to continue to allow people the opportunity to network. This is just giving folks at children's hospitals across the country a forum for exchanging strategies, exchanging ideas related to disaster management, and exchanging the knowledge base that we've got across the country related to pediatric disaster preparedness, along with kind of pushing the agenda of collaborating with healthcare coalitions and community partners. This just, again, leads to number 2, which is engaging and learning from others and sharing the expertise and program models. For number 3, I think we've seen numerous times throughout the pandemic the struggles that healthcare has seen, and we hope that through improved preparedness, we have increased resiliency in the healthcare systems across our country. And 4 being access, which is really, we're hoping to provide a lot of these resources to you in a very easy to digest manner, as well as access to tabletop exercises and drill templates that can be used throughout the course of the collaborative to make the burden on emergency managers and disaster leads much less than they would be normally. In addition to that, additional resources related to work that the PPN has done will be shared, and this is really going to be, I think, make it as easy as possible for people to improve their performance and be able to measure that improvement so that we have data to show the improvement that's been made and really measurable success. And the last being skills enhancement, innovation, and risk and liability reduction. Skill enhancement, we know that these are going to, we will plan on providing continuing education credits. So this is going to be something that the individuals participating will be able to get CE for. We know that plans tend to sometimes divert from kind of standard operating procedures to crisis standards of care, and maintaining these plans in a contingency standard of care perspective is ideal state. And then from a C-suite perspective, risk and liability reduction is something that always gets people's attention. And so we really hope that this is another selling point for participation in the DNC. We know that there are a number of children's hospitals out there that feel like they've kind of done a lot of work in this space. I think I work at one of them at Texas Children's here in Houston, but there's always ways to improve upon what is already in place. And that's what we really hope to do, is not just make sure that we all have a good foundational level of preparedness, but can improve upon some of the successes folks have already had. Next slide, please. So some examples of some best practices that we've seen shared throughout the Disaster Networking Collaborative and things that we intend to embed in the work of the Disaster Response Collaborative are things like this. When Dr. Roxana Lafort at Riley Children's Hospital shared job action sheets that they have for mass casualty incidents. So this is a variety of different quick sheets that really show the step-by-step approach that individuals in a variety of different positions should use when something occurs in their community. And these are the sort of things that we hope to highlight and share throughout the Disaster Response Collaborative. Next slide. And, Pat Frost mentioned in the Q&A, how do we get children's hospitals to engage better with healthcare coalitions? We hope that we've accomplished that somewhat during the Disaster Networking Collaborative, as we've really stressed engagement with the emergency management landscape in children's hospitals and in their regions. But we see healthcare coalitions as a prime forum for getting this work done beyond the walls of the children's hospital. Healthcare coalitions serve as a community of all those involved and embedded in disaster preparedness and response. And it's a terrific place for those children's hospitals to further engage with community members and other individuals on a state and regional level involved in disaster response. Next slide. So the registration for the Disaster Response Collaborative is currently open. Here is a QR code you can scan to register for the DRC. There will be numerous websites and resources to follow, but that first session is not coming up until August 6th of 2024. We just wanted to start planting the seeds and getting folks, encouraging folks to participate. And please, as we mentioned, we will be sharing this information after the webinar. Please encourage other children's hospitals to participate in the DRC, those that may not be in attendance today. But there will be many other opportunities to register in the future. Next slide. And finally, while we don't have the ability to unmute folks that are participating or attending the webinar, please encourage folks to use the Q&A for specific questions they may have, and we can address those while we have this esteemed panel present from this webinar to assist with folks that may have questions related specifically to the Disaster Response Collaborative.
Brent, I wondered if the panelists might want to make some final comments, beginning with Dr. Remick.
Sure. Thank you, Laura. And, hopefully we've just given the case for why joining this collaborative could be useful and helpful and is so important. Really, we're just here to help guide and support and grow our network of children's hospitals. So thanks so much for joining today, and we hope to see you in the collaborative.
Thank you. Other panelists, final words, things you didn't get a chance to say.
I would just like to encourage everyone when they're thinking about forming their team, as somebody who is junior faculty, think about the senior fellows or folks in even residence, or your junior faculty members who have just come on. Think about involving them on the teams. It's really important to kind of train the next group of folks who are going to be pushing this forward. And I know that they'd be excited, and sometimes they're just looking for a foot in the door or a seat at the table.
Dr. Chung, Dr. Simpson, thoughts?
Oh, I think, as Brent said, I think even if you're an institution where you have some plans, it's nice to be able to create this network where you can talk about your plans and see what other places have done. And so that you're not working in a vacuum, you're all working together for the same purpose. And so I think of that, especially like we've all experienced surge, we may have all created different things. And that maybe, this will allow us a space where we can share what we did and how well or how not well it went, because that's equally important. I'll turn it over to Joelle. Thank you.
Yeah, I can echo everything everyone has said. I think there's really been no downfall for me in being part of a network, especially like this, even in the planning of this session and sort of learning from others in the way that they approach things at their institution. The part of this that I'm particularly excited about is part of what Johnny mentioned, which is that the additional members that we can think of to be added to the team that are not your sort of the typical players in this space. Pediatric emergency medicine and nursing and so forth are often at the forefront of this sort of work. But I think that especially with the pandemic, with more and more people being involved in response on some level, it's going to enrich this experience even further if you're able to get those folks at the table as well. And I think this would be tremendously worth their while. So I really encourage the creativity of building teams that are diverse, so we can learn not just from our typical disaster folks, quote unquote, but also the people who are have been at the sidelines and really should be more front and center in disaster planning and response.
And, in that vein of like, everyone has room for improvement, that new president at Texas Children's Hospital, Dr. Debbie Sukin, uses a phrase that I think is terrific, which is better has no boundaries. And I think we can always improve and make progress towards improvement. So I know that there are sometimes folks that are like, oh, we do all this, we're so good at it, but I think there's always room for improvement. And that's why I encourage folks to register and join this journey, because even if you might not make huge strides for improvement in those sessions, you're going to be able to share some of the strategies that you've implemented and really help other children's hospitals across the country.
I wanted to mention one thing too, in case it wasn't obvious. Even if you didn't join the Disaster Networking Collaborative, if you work at a children's hospital, we really want your children's hospital to join us. There will be one extra session if needed to help those who weren't part of the Disaster Networking Collaborative. But please come along with us and join us on this important journey. You continue to amaze me with the fact that you save lives, you share your expertise, and we are all very grateful. Any more final comments? Julie, can you show the last slide? So the email in blue up top is how you can get a hold of us. And then if you go to the homepage for the PPN, you can see all of the ways to connect via social media, and there are a lot. And you'll get updates on sessions and other things. The podcasts are worth watching. Dr. Kasny and Dr. Simpson both have recorded and available podcasts. They are simply amazing. So thank you, everyone. And if the speakers have time, if you could stay on briefly, and the rest of you can go on with your day. Thank you so much.